Good morning, and thank you for joining us again. One of the foundational missions of our department is to provide a resource-rich environment that attracts the future leaders in medicine, science, and anesthesiology. And once we attract these leaders, we also make sure we resource them to realize their dreams. Later on this morning, you'll hear from a lot of our graduates. They'll tell you a little bit about what they've been doing, and then we'll follow that up by a live panel discussion.
I get up in the morning and just am excited about what I get to do. And especially when I get to talk about palliative care and how to integrate it into ICUs and perioperative settings, and to really turn people on to how this can be such an amazing tool to help them provide better patient and family-centered care. That's just one of the best things about my work. I don't think I would be a critical care anesthesiologist if it wasn't for some of the amazing women who were critical care anesthesiologists at MGH when I was a resident, who I could look at and say, that's who I want to be like. I want to be like her. It's very hard to be what you don't see. So in academic medicine, in critical care, in anesthesia, we need female leaders. We need leaders from communities of color. We need leaders who identify as LGBTIA, because our trainees are from all those communities. Our patients are from all those communities, and they need to see themselves in who we are.
The Mass General with the Ether Dome is really the Mecca for anesthesia, especially people who are interested in the discovery of anesthesia and history in the early days. And it's such a rich history in general, but especially being there, which was really, the cradle of American and anesthesia, certainly, and ultimately the cradle of anesthesia for the whole world.
They weren't looking just to have a standard output of their residents. And I did some offbeat things during my residency. For example, I was a fellow of the American Psychoanalytic Association, and I did a research fellowship in psychoanalysis. And I was supported in those activities. I was allowed the time to go to meetings on psychoanalysis or consciousness. And that really speaks to the vision of the leadership and the culture of really trying to promote thinking, individual paths. And that's something that certainly had a very positive influence on me, and that I appreciate as I reflect on my time at MGH.
Here you are, this young resident, you really don't know a whole heck of a lot, and you're talking to giants in the field. But when you're talking with them, you realize that they're just like you are. And as you evolve and develop into what others will eventually perceive you to be, a giant in the field, you recognize that they all started at the exact same place that you were. One of my fondest memories is one that would be not even heard of now. We all slept in bunk beds, men and women in a room. It just didn't matter. You were so tired when you went to sleep. But if you heard anyone's beeper go off, we were such a great team. We were in the bunker together. Everyone got up, everybody went down to the ORs, and we helped one another. I think that's probably the greatest experience about MGH, is the collegiality, in particular among the residents.
So I would say that somewhat snarkishly, that at least MGH didn't stop me from becoming an anesthesiologist and deflect me in my career path, but my career path was a random walk rather than a path. And I'm so grateful to MGH for making it possible for me to A, survive, B, thrive, and put up with me while I had some direction changes, creating a fertile environment with a lot of diversity of thought and a lot of ideas, personalities, which is something that a department with a lot of size and a lot of resources can do, is something unique that MGH is positioned to do, partly because of its long tradition, partly because of generations of careful development of resources to make it possible for a department to do the things that MGH does.
It was a very exciting time because I really felt like it was the nexus of anesthesiology training, and particularly critical care, where so many leaders of the critical care field were working in the ICU, and I was rounding with them at that time. The MGH taught me to focus on the problems that are important, on the problems that really matter for patient care and for medicine in general. And I think that attention to what's really important and what matters has shaped my entire career.
They had a different way of teaching. It was not hand-holding. So they would watch and see how you got out of trouble. So long as no patient was harmed in any way, they would let you be creative and do what you thought would be a good idea, and then tell you why it was not.
What I value most, I suppose, is the privilege of being one of a very long tradition of caregivers who invest themselves and their efforts and their training towards a good and legitimate goal, which is to offer care in a safe way. That business of accepting the responsibility for another person who has chosen to put themselves in my care for a period of time, or their child in my care for a period of time, and then that I've acted upon that reasonably well, I would find that the most fulfilling part.
One of the things that I really enjoyed about the Massachusetts General Hospital experience was the camaraderie I had with the residents and my peers. We would play basketball on Saturday mornings at the Charlestown Navy shipyards. And by engaging with one another at a level to see the excellence of people clinically, but also see the personal and humanistic side of folks when you're engaged in sport, was really an important aspect of my being at the Mass General. Almost my entire career has been trying to increase diversity in the workforce in medicine. Increasing access, I think, is the most important thing we can do to eliminate health disparities. And so I think that the work that we're doing is so important, because we'll be able to get practitioners who will be able to focus on those communities that have been underserved for so many years.
When you train and practice at MGH, you become part of a network, a very strong network. And once you graduate and have that sort of network of friends and colleagues, they're always there. And they're very successful in academic medicine, and you rely on them over and over again. There's always somebody that you trained with or knew or who taught you or was behind you, who's doing something that can be helpful to you. And it's been incredibly useful for my career.
The difference between what we know now and how we're able to apply it and what we knew when I started almost 40 years ago is amazing to me. The most influential people I met at MGH were my co-residents and trainees. We really bonded with each other. I met remarkably talented people. We've become lifelong friends. And we formed a professional network that has lasted our whole careers.
My mantra is that increasing workforce diversity actually helps patients. It actually improves relationships. It actually changes patient adherence. And having workforce diversity actually improves cultural competency. We owe it to ourselves to say that there's value in diversity. And I think Mass General has appreciated that. And I appreciate what is being done and senior leadership at Mass General, even today, with diversity. COVID-19 was such a challenge for hospitals. Anesthesiologists became rock stars overnight. Suddenly, everyone appreciated the role that the anesthesiologists played.
The MGH was much more entrepreneurial, much more interested in advancing the cause of medicine, and then I think most institutions at the time. I mean, not only were we expected to provide outstanding medical care, but we were expected to advance the ability of physicians. I remember one of my colleagues in particular said we represented the last court case for a number of patients throughout the world. And we had patients coming in from literally from all over the world. And the sense was that if there was an answer for them, we were the ones that needed to provide it.
I loved every minute of my time here. It's such an amazing place full of amazing people. I came as a CA1 and then was junior faculty for a time here. And it was just a wonderful place, both in terms of the clinical care we provided, the research opportunities. It was a very intellectually stimulating environment. It's an amazing place.
The research environment is just absolutely outstanding at Mass General. It really is, can't be surpassed. The breadth of the research that's going on at that institution is amazing, and I wanted to be part of that. I went to MGH to do my residency and ICU fellowship, and I intended to head back to San Francisco at the end to be with my family. But I stayed. Circumstances changed, and I stayed for 15 years. Why? Because I had a fantastic time at MGH. A huge thank you to the MGH Department of Anesthesia and Critical Care. I cannot think of a better place to have trained and to have started my career.
Hello, I'm Jesse Roberts, a pediatric anesthesiologist and pediatrician at Mass General Hospital. For the next about 30 minutes, it is my privilege to moderate this session entitled The Current State of Anesthesiology. But before I open the discussion, I'd like to briefly introduce, in alphabetic order, our distinguished panel members. Brian Bateman is currently chair of Department of Anesthesia at Stanford. He was a resident at the MGH from 2007 to 2010, a chief resident in 2010, and he was part of the faculty at the MGH from 2011 to 2015. Deborah Coley is the chair of anesthesia at the University of Pennsylvania. She's a Robert Dripps professor of anesthesia, and she was also a resident at the MGH from 1993 to 1996. Judith Hellman is the vice chair of research of anesthesia at UCSF. She's a William Young professor of anesthesiology there. At the MGH, she was an anesthesia resident and critical care fellow from 1993 to 1997. And she was on our faculty until 2008. And George Mashur is a chief of anesthesia at the University of Michigan. He's a Robert Sweet professor of anesthesiology. He was an anesthesia resident at the MGH from 2003 to 2005, and he was a chief resident in 2006. And Laura Nicholson, until recently, was the Nicholas Green Chair of Anesthesia and Biomedical Engineering at Yale, and she's currently an adjunct professor of anesthesiology and biomedical engineering at that institution. She was an anesthesia resident and critical care fellow from 1992 to 1997, and she was on our faculty at the MGH from 1997 until 1998. So quite a distinguished group of people. And I'd like to throw out the first question. How did your time at the MGH shape your view of anesthesiology and help you establish a vision of how our specialty should grow in the future? I'm interested in anyone's thoughts.
Well, I'll start simply because I'm looking at this group of individuals. All three women that are here today had some overlap at MGH, and I think that had a profound impact on me and who I was as an individual and how I grew and developed. When we were residents there, roughly 40, closer to 50% of the residents were female. So when I went out into the community, and as chair here at Penn, and I see that there's only 20% of my faculty that are women, I recognize that there's still a lot of growth and opportunity, but I think I picked that up from having had the opportunity to work with both Laura and Judith over the course of those years when we were residents together.
I would like to sort of echo that I was actually looking at everyone, realizing that I think I overlapped with absolutely everyone on this, minus maybe Brian Bateman, but I think even you and I overlapped. And, you know, I guess I went to Mass General because I was interested in critical care and anesthesiology. And there I continued to discover how amazing that field was, but also how much more there was to anesthesiology, you know, beyond even the clinical kind of walls of anesthesia in critical care, pain management, research, policy, and so, you know, done by a lot of people that are really fun to work with in all areas. And it's kind of, you know, illustrative just to see the group of people here because all of them in different stages of my career have really influenced me, and sort of a lot of that was actually during our earlier stages as residents and fellows at MGH.
I would say my time at the MGH gave me a real vision for the role of physician scientist. There were a lot of really wonderful faculty members who were fantastic anesthesiologists, but who were asking really important questions and doing really important research. And it gave me an idea of the type of career that one could have combining research and clinical work.
I would just like to echo that. I had a very similar response in terms of seeing these just shining examples of faculty who are embodying the spirit of being a physician scientist, including Dr. Hellman, who was one of my attendings in critical care when I was a resident, Dr. Zapol, Emery Brown, the list can go on and on. But I think that really helped form a template or model for a vibrant career as an academic anesthesiologist.
And I guess I would just finish up by saying that in addition, I obviously agree with everything that's been said, but I also feel like my training at the General really taught me to think of myself as a complete physician and as somebody who was very integrated into the care of the patient, you know, throughout their stay in the hospital. And, you know, the position of anesthesiology in the Harvard system and in Mass General in particular was always a very sort of prominent and special one. And I think it really changed the way we think of ourselves in terms of our role in the hospital and our role in really driving outstanding patient care. And I think that's one of the big reasons that so many leaders have been spawned from that program.
What has made anesthesiology an exciting, fun, and rewarding medical specialty to you?
I would just say that, you know, one of the key reasons I went into anesthesia was that it allowed me to take care of the whole patient rather than being in a sort of a narrow specialty where I only think about the patient's skin or their eyes or their heart. We get to take care of the whole patient, which is very intellectually stimulating and rewarding. But pursuant to other things that were said on this panel just now, being an anesthesiologist also allows you the flexibility to really establish a strong research career. And so it was that great hybrid of having the flexibility around your schedule and commitments so that you can have a robust research career. But at the same time, when you're taking care of patients, you're taking care of the whole person.
Just to play on that hybrid, I actually started off in psychiatry at Mass General and McLean. And I just started getting so interested in acute care physiology, and I was struggling with this decision because I went into medicine and neuroscience to study consciousness. And then when it was suggested to me that I should consider anesthesiology as a discipline, the light went on. And I have to say, to this day, as somebody who's really interested in human consciousness and animal consciousness, being able to take care of patients, modulate their level of consciousness, and then go off into a lab or a clinical research setting and pursue these questions has really made it a vibrant experience for me, not just professionally, but personally.
I would like to echo that, the diversity of the areas, clinical areas and research areas, the people, all really make it give opportunity to look at so many different, from the research standpoint, so many different disease processes, physiologies, acute, chronic, and to be thinking about it in a really clinically relevant context. And I had the experience as a junior intensive care faculty at Mass General to see patients, one in particular that had huge vascular leak, and I started to think about the endothelium, and at the time was doing a lot of kind of work with bacteria, and I wondered whether or not there's inflammatory pathways in endothelial cells. And then that became a whole line of inquiry that persists 20 years out. So just I like the kind of interplay between the clinical arena and the basic translational and clinical research areas a lot.
I think one of the things that I enjoy about anesthesia is that it sits at the nexus of so many different fields of medicine. Surgery, obviously, but also cardiology, pulmonology, endocrinology, infectious disease, neurology. We touch on so many different specialties in the course of our work. And I think that makes the clinical practice of anesthesia really exciting, but also the range of areas where we can contribute as researchers. And I think when you look at the research coming from anesthesiologists, it's really touching on so many disciplines.
Yeah, I would add to that. For me, it really was a unique opportunity to take someone through the most difficult period in their life, tell them that they were going to be okay in the beginning, do everything that you could during the middle to make sure that happened, have them wake up and go home without really recognizing the degree of a physiologic insult that they'd actually experienced. I originally wanted to be a neurosurgeon. I thought I wanted to be a neurosurgeon, but it very quickly became obvious to me that would not allow me to see my children, and they were really important. But anesthesiology was special because I could take that look into the brain, as George had previously discussed, to try to figure out how the brain works and how we put people to sleep, how we wake them up, and whether or not there are any adverse results of having done so. So it's a great subspecialty, and I hope that many people will follow in our paths.
Wonderful. Another question I have is, what do you find the most important and hot area of anesthesiology today, besides your research?
I'll try that one. It's wellness. It's trying to help our faculty recognize, in particular during the period of this pandemic, when people are being paid to stay home and they're required to go to work put themselves in harm's way and potentially their families and really stand up to that. We've had problems with wellness before the pandemic, but I think we really need to recognize that the world has changed. The idea of us having 60 to 80 hour work weeks is probably not realistic anymore. And we need to make sure and take into consideration their personal needs as well as our patient needs. Because if we're not taking care of ourselves, we're not going to do a great job taking care of our patients.
Judith, what do you find to be most important and hot in anesthesia today?
So I'm going to probably come at this from the research angle, and what I am seeing from that standpoint is data sciences. I wouldn't necessarily say it's the most hot, but it's one of, it's among the top. Included in that is I second you on the wellness aspect of it, and the fact that this is an endurance situation, not a sprint through something. But in terms of, I think that data sciences is proving to be important in so many different areas of clinical work and research, basic translational and clinical research. Getting a handle on that, understanding how to use data to answer important questions and to drive technology, discovery, and treatment, I think is important, is something that's going on in anesthesia, and in a lot of ways is kind of in its I'm not going to say nascency because it's very well advanced, but still has so much potential for evolution, for standardization of methods, et cetera, and for driving the practice of anesthesia, critical care, and even pain medicine.
And Brian, what are your thoughts?
I agree with Judith about data science. I think that's going to be a really important aspect of all of medicine in the years ahead, and for anesthesia in particular, as a very data-intensive specialty, the tools of AI and machine learning and applying them to the OR and the perioperative period to guide decision support, but also to inform discovery in those areas. I think that's a really important direction. I'm excited about the number of large pragmatic trials that are being done or that are kicking off. Trials that really I think will inform our approach to patients in the OR, whether we should be doing spinals or general anesthetics, the benefits of TIVA versus general anesthesia. That's really exciting work to me. I guess people have been talking about it for a long time, but the conceptualizing ourselves as perioperative physicians and really understanding where we as anesthesiologists bring value across the perioperative continuum, from preoperative evaluation, rehabilitation, getting patients through the OR, and then taking care of them as they recover from their surgery, and understanding trajectories of recovery and how we can influence that, how what we do in the OR impacts on long-term outcomes. All of those areas are, I think, very important.
And Laura, what do you think are the important hot areas of anesthesia?
Well, I think that pain medicine and addiction science obviously has continued to be a real, it's been a burden on the U.S. and frankly countries around the world. And unfortunately, I think it's going to continue to be so. Different forms of, new designer molecules are being brought into existence all the time, many of them very addictive and harmful. And anesthesiologists, as being people who understand pain and understand addiction and understand these substances and also understand changes in consciousness, I think really should be leading the way in the basic science and in the clinical trials that are involved with mind-altering substances, because unfortunately, I think this class of problem is going to be with us for decades.
And George, what are your thoughts?
So I would echo all those comments. I think they're all critically important topics. I will say something that I've been thinking a lot about very recently are the environmental effects of anesthesiology and some of our anesthetic choices. And I know these data have been around for a while, and I will admit I just haven't really faced them as I should. But I've really been thinking a lot lately about, even within the range of halogenated ethers, the dramatic differences between something like desflurane and sevoflurane, which normally we would consider fairly comparable, just have wide differences in terms of their global warming potential. Nitrous oxide is now considered to be the major ozone depleting gas, and this is on us, and something that I feel like we can and should grapple with, because we have choices, and these choices are going to have long-term implications. For example, the atmospheric lifetime of nitrous oxide is over a century. And so these are things that I haven't been thinking about, and I've started thinking about it more recently, and I think it is really important as we grapple with topics like anesthetic neurotoxicity to also consider anesthetic geotoxicity in a broader sense.
Very interesting. What, if anything, do you think should be shored up in our current practice of anesthesiology to ensure our specialty's robust future? So this is looking ahead.
Well, I'll offer one comment just in thinking about academic departments, for example. I think we need to be broad thinkers, and we need to not only focus on advances in our field, but think about how we can position ourselves, and we are well positioned actually, to answer broader questions of more general relevance to medicine, to science, to society. Pursuant to the earlier point, we touch on so many different specialties, so many different aspects of medicine and science. We really have a great opportunity to embrace that breadth and think about how we can be the kind of force that really helps all fields rise. And I think, now as a fairly new chair, realizing we have enormous influence in the health system. I mean, we're everywhere. And thinking about how we can have the same kind of research and academic necessity to the academic medical center, I think is going to be a key for us to have a vibrant future.
Deb, what do you think should be shored up, if anything?
I would agree with everything that George has said. Those are unbelievably important, but there are a few things that people are really going to want to address that we need to think about in our future, because there's a lot of angst between different practitioner groups, and really learning how to work together as a comprehensive anesthesia care team is going to become more and more important. There is no way that we're producing enough anesthesiologists to meet the needs within the country. So we're going to have to learn a way to do that in a manner that's respectful of all practitioner levels. And we can probably utilize things like artificial intelligence to help us to do that in a more cost-effective manner. So I think we're going to see more of that in the future. We're not there yet, but if we're dreaming, that's the kind of thing that I would dream about, kind of some computerized or IT support for some of the decision-making that's happening by providers that might not have our level of experience, and us being utilized primarily as those individuals who are dealing with patient problems, more than just sitting on the seat in the operating room.
So Brian, is there something that you think that should be bolstered to help ensure our future?
Yeah, I'll echo some of the comments George made. I think research is extremely important to the future of the specialty, and I think academic departments need to really make sure they have a continued commitment to training the next generation of researchers, putting resources towards supporting the research mission, encouraging our researchers to ask really important questions that have important public health significance, and make contributions to the broader field of medicine.
And Laura, do you have thoughts about this?
Yeah, I guess I would land actually pretty close to where Deb Cully suggested, in that I do believe that as medicine is evolving, and as the range of sickness level or of acuity of our patients has become so broad, that that having physician anesthesiologists in all cases is as we know, not realistic, but trying to understand how we can best work together as a team with nurse anesthetists. But also, to Deb's point, I would think that to make situations maximally safe, where we have perhaps less experienced or less trained caregivers, that's really I think a situation for artificial intelligence, but also better non-invasive monitoring techniques, better methods of really understanding what's going on with the patient, whether it's looking at their vascular tone or at their gas exchange or at their cardiac output. Really having outstanding non-invasive tools that we can leverage with patients and then monitor those. That would really, I think, allow us to keep patients safer and to use our fully trained anesthesiologists, again, more intelligently to really fight off problems or to care for the very ill.
And Judith, do you have thoughts about this?
I definitely would echo the thoughts about kind of continuing to shore up research in our specialty, and that's a kind of an ongoing thing that needs to be paid attention to as the healthcare system evolves and as research evolves. And to touch on the idea that anesthesiology is a multidisciplinary area that extends to research as well, and to, I think, trying to shore up the role of anesthesiologists, intensivists, pain physicians in kind of the world of science and multidisciplinary big data or big science research, I think is something that would be helpful in continuing to maintain the strength of the discipline in all areas. Along those lines, also, continuing to evolve with the educational evolution, the paradigms change over time, and those are things that I think are continuing to evolve, and that we need to always be paying attention to shoring up over time.
Great. Can you share with us important threats that you have identified for anesthesiology?
Mass General is like leading the way. It's great.
Yes, that is something. And that is something that's actually very important since you brought it up, Laura. The development of leaders is something that I haven't seen being done to the same degree as I would like to see it. Oftentimes, we can put ourselves in those settings, as everybody's discussed previously. We have an important role within the institution, and we can utilize that role to really lead not only our departments, but as well the institution with regards to patient care. And I think that the threat there is that if we're not developing leaders within each of our departments, we will lose the presence there. So I would encourage all of you who are chairs, all of you who are leaders, to continue to develop your leadership team. I had somebody say to me recently, I believe in succession planning and developing leaders, and they said, well, why would I develop my replacement? And my response was simple. Why wouldn't you? If you really want a better world and you want this to be a better place, you need to develop your replacement. So I'm sitting here right now trying to develop mine, and I think we should all be doing that.
Do you agree, George?
I always agree with Deb. No, I think that's a great point. I mean, we definitely have to think about the next generation. I think we have to define excellent leadership as having an enduring and sustainable positive effect, and that means training others around you. I think diversity is critically important, and we're starting to focus on it more as a field, I believe, but there's a lot of work to do. And I think one thing I would point out, because oftentimes people raise concerns about academic anesthesiology or anesthesiology in particular as being under threat. And I don't believe that's the case. I think all fields are undergoing threats right now. but also opportunities, and thinking about how to move forward and not be trying to hold on to a past that is no longer relevant, but thinking about what is our role. And this actually touches also on Deb's point about the team-based care. What is our role as anesthesiologists in the 21st century to advance health and to advance understanding? So I think we need to work with other disciplines and come up with creative ideas to keep the academic culture vibrant, because it is under threat, even at major academic medical centers. There are a lot of pressures and constraints that are encroaching upon it, but I do think that there are opportunities.
Brian, what are your thoughts about this? As a new chief of anesthesia at Stanford, you probably have thought about what kind of threats there might be for our specialty.
I agree with the comments from the other panelists, and I'll turn the question on its head a bit and just maybe talk about some of the things that I think are really exciting about the future of the field. And one of those is the number of or the interest of medical school graduates in the field of anesthesia. The quality of the residency applicants that we've seen in recent years is just really, really tremendous. People that have a huge amount of promise. It's also really exciting to see the next generation of researchers coming up, and the really tremendous work that they're doing in so many aspects of from basic science, translational science to clinical science. And so I think I'm really hopeful about the future of our field, seeing the trainees that are coming through and the contributions that they're starting to make.
And Judith, have you recognized any things that we should be aware of, or any threats that we should be considering?
I think that threat is such a such a harsh term, and I would go back in a way to George's, I believe it was George's comments about opportunities, and rather than I think that there's that, and also about the concept that it's not anesthesia, it is the larger academic medicine that may be always under some stresses and needs to evolve to meet the times. And so I think if I had to name a threat, it would be getting too mired down in the past of the way it was and what worked previously. All of those things that worked previously were completely valid at those times. The healthcare has evolved. The ability to do research by healthcare practitioners has evolved. And I hate to keep harping on data sciences, but there's a large opportunity in that for anesthesiologists who are not the 70 to 80% researchers, but do have extremely good clinical research ideas and insights that can be studied at a less than 70 to 80% commitment. And I think that that's an area that we need to kind of solidify our training process for, and our resources as a discipline to support people who are interested in doing different or pursuing different ways of doing research than might have been the norm for when I was training, for instance.
I just want to thank our moderator and all our panelists for giving us a great sense of what it is to be an anesthesiologist, and certainly how we need to reshape academic anesthesiology. Now we'll transition over to a break.